The notion of helping the body heal itself made sense to me versus how I was trained, which was medications, steroid injections, and surgeries. This filled a gap. We have something to offer those people that aren't quite surgical, but aren't responding to traditional therapies. It got us in the game. And that was so critical to have because we had so many patients in therapeutic limbo suffering with this stuff. To answer your original question, I wish I got to people sooner, but the problems often aren't severe enough to get them through my door. In theory, if we intervene earlier, the problem's not quite as bad. We should not only be more effective, but also have the opportunity preventatively to lessen the likelihood that the problem's going to advance as quickly or as severely over time.
Dr. Karli, let's talk about stem cells. And I think maybe where I'd want to start with you here today is I don't think defining is the right word here, but if you can, to a complete outsider, somebody that has no background or understanding of stem cell therapy, what is stem cell therapy and what are some of the common myths or misconceptions that people believe when it comes to how to effectively use these in their health, nutrition, longevity?
Yeah, great question, and probably a whole podcast in and of itself in terms of the answer. First of all, thank you so much for having me on the show, Frank. It's an honor to be here, and hopefully we can provide some good information to your audience. Regarding stem cells is a very generic term, and what you got to understand is there's a lot more to it than just applying stem cells. Stem cells are many different types of cell populations that normally live within our bodies. In almost every tissue in your body, there are stem cells. Now, some tissues have more than others, but almost every tissue from your brain to your bones to your muscles to your heart have stem cells within them. In our bodies, the function and purpose of those cells is to maintain something called homeostasis. Fancy word. All that means is health. Those cells are designed to keep our tissues healthy. Okay. Now, in terms of application of stem cells as a therapeutic treatment, okay, there are many different types. In the United States, and our research focuses on using the patient's own stem cells. Also, from a regulatory standpoint, there's a lot of regulation, which I'm sure we'll get into over the course of the conversation, but stem cells is a bit frowned upon in terms of the Food and Drug Administration and what we're supposed to say to categorize cells that we're using to treat patients. A better term is probably something called progenitor cells. And that is a little better description because it more aptly describes many different types of cells in our bodies that have therapeutic potential, meaning we can apply them to a knee arthritis or a tendon injury or ligament injury, and they have the capacity to stimulate improvement in symptoms and potentially in healing. So it's a very broad category, okay? Stem cells from the person's own body are what we call adult stem cells, okay? Stem cells isolated from a person, from an adult, from a human being. That is also called autologous. Autologous means from you. If I take your cells and apply them back to you, that's an autologous therapy, opposed to an allogenic therapy, which is where the cells are isolated from someone else. So one of the common models that you'll see throughout the world is from birthing tissue, from cells isolated from a placenta, for example, or amniotic fluid, or something called Wharton's jelly. Those cells are grown in a laboratory in culture, put into mass manufacturing, and applied to a patient. So they're not your cells, they're not your DNA, someone else's applied to you. So autologous from you, allogenic from someone else. Now, why is that important? It's important because one is compliant with the Food and Drug Administration and one is not, okay? And if you're researching stem cells as a consumer, you're going to see physicians applying both in the US. Right now, legally, and this is a really important thing to remember if you're a consumer looking for cell therapies in the United States, the only one we can legally apply outside of a clinical trial is autologous, is your own.
Okay.
Everything else, allogenic stem cells, are considered a biological drug by the Food and Drug Administration. That means they have to go through preclinical animal testing, phase 1, phase 2, phase 3 testing like a pharma drug would in order to get an approval for routine clinical use. So the only way someone else's cells can be applied to you in the United States is via a clinical trial. No other way. Yet it's happening every day all over the country in the United States. Now, in some other countries, that is allowed. Okay. But in the US, that's the deal. Okay. And we're seeing a lot of legal movement and so forth from the FDA enforcing this rule, which has kind of been ignored by and large. And we can get into the merits of autologous versus allo and all that kind of stuff if you want. But that's really one of the important things that a consumer who's interested in cell therapies or stem cell therapies needs to know. If it's not yours, it's not legal in the United States outside of a clinical trial.
Got it. Yeah, no, that's good. And there's a lot there for us to unpack and kind of pick apart there a little bit. And I appreciate the distinction. I mean, I can remember this was probably 5-6 years ago was the first time I can really remember stem cell therapy being talked about, not even mainstream at that point, but you'd hear it in kind of, I've operated in some high performance circles. I have friends that run health optimization clinics. Probably about 5 or 6 years ago, I remember people starting to open up clinics overseas or down south. They would go into, Panama, they would go into South America. I had a friend that just went to Tijuana to get some therapies. So they're going to those other places because they have access to other people's cells. Would that be the main reason as why somebody is going overseas or out of the country to get the therapies?
So offshore models allow things that in the United States may not be allowed. For example, using someone else's cells. Now, the very interesting thing about that, and while we're on that point, my research team, our PhDs, I have tasked them with constantly scouring the research, the literature, the published information every single week. And I tasked them to find me one study that matches patients. So the same patients, two groups of patients with the same problem. One gets allo cells or cells from another source, and one gets their own, assuming they're reasonably healthy, and compares them head to head in terms of which works better. To date, there's not one. Not one. So this debate of are your cells better or is someone else's cells better? Are younger cells better than your own? I'm 60, I'm 70, I don't have good stem cells anymore. It really has been defunct scientifically because we've proven that 60 and 70-year-olds respond fine to their own stem cells if they're in reasonably good health. But in terms of what's better, the argument for the offshore model going to other countries is, well, these are younger cells. They have greater life force. They have greater vitality. They have more therapeutic, robust potential. It's never been scientifically proven nor defined. Now, it could be that is true, but it's never actually been defined. And the one thing I tell patients that I know for certain is if I use your cells, I know they won't hurt you, right? You can't reject your own cells, and they are genetically coded, perfectly genetically coded to keep you healthy. So right now, our work clinically and our research work here and abroad really focuses on optimizing use of the patient's own cells, which is very safe, very low risk. It's regulatory compliant, meaning we're not breaking any rules to do it. And right now, all the data supports that versus another model. Over time, that could change. Okay, there's all kinds of different ways this could go. But the state of the art today is that your cells, if you're healthy, still work really well, and they're also extremely low risk. Now, one of our tasks as clinicians and scientists is first do no harm. Don't cause more problems than you solve. And regarding these foreign DNA models, there's now evidence starting to come out that they're not invisible to the immune system. They're recognized, meaning they're killed off shortly after they're put into your body. For a long time, it was thought that these birthing tissue cells, because think about it, there's a mom and a baby, and baby is part dad's DNA, and they don't want mom's immune system to attack dad's DNA, so there's these specialized cells that prevent that from happening. Let's go use those because they're going to be invisible to the immune system. It turns out they're not truly invisible to the immune system. So again, we can get into a super deep dive on the science part of it, but right now, in terms of my clinical counseling to patients, I'm recommending your own if you're healthy, and we can get into dosing stem cells and all that kind of stuff, which is really the crux of our work and my biotech company. But that's the model that seems to work best for the time being.
Yeah, we may go a little nerdy on the science stuff here, but I want to gear at first to maybe application and who it is that you guys are treating and who can stem cells be effective for. I think when I was hearing about them 5-6 years ago early on, and probably even still to today, I think most of it is going to be rejuvenation, bouncing back from injuries. Is that still the main prescription that people are using this for, is for a recovery mechanism? And how has this kind of evolved over your short time?
Yeah, so you used a really great characterization, rejuvenation. Okay, a lot of times cell therapies are lumped under this term regenerative medicine. But in truth, we don't regenerate a whole lot when we apply these types of therapies. So I don't take a knee arthritis and regenerate it back to 18 years old again. Okay, there are limitations in what we can regenerate, even though we call it regenerative medicine. Rejuvenative medicine probably would be a more apt term. We're stimulating those tissues to become healthier, but we're not necessarily regenerating them. Now, how do you rejuvenate them? You reduce the inflammation that's caused by pathology, arthritis, degenerative changes, tears, etc. Okay, that chronic inflammatory environment degenerates tissues. So if you control that chronic inflammation, it doesn't hurt as much. You feel less pain. That improves your function, and it protects the tissue from continuing degenerative problems simply from the inflammation alone. So it's kind of a negative feedback loop. You get arthritic, you pump out tons of inflammation, that makes the arthritis worse, which makes more inflammation, and it's a slippery slope. And that's how we degenerate. In terms of applications, my background is in orthopedics and sports medicine, musculoskeletal medicine, bones and joints and ligaments and tendons and so forth. This field kind of grew up in that space for a number of reasons. The first one is those tissues, tendons and ligaments and cartilage, have no direct blood supply, so they can't fix themselves when they get hurt or damaged or degenerative. If you don't have blood flowing to it, the body can't heal or fix it. We call that an avascular tissue. And all the problems that we have orthopedically in our lives as we age stem from tissues that have no capacity to fix themselves. So logically, how would you attack that model? Well, you would take elements of your body that heal, that can't get there. You would concentrate those and apply them either by injection or surgery to the tissues where they can't get to, and then let them do what they're physiologically designed to do. It's a very simple premise, but that's really how cell therapies work. Okay. Now, orthopedics is particularly near and dear to not only my background, but health from my perspective. Your Superhuman Life podcast. Well, one of the biggest limiting factors in us living a superhuman life as we get older is the orthopedic limitations that are imposed as we age. How do you keep your heart healthy? How do you prevent metabolic syndrome? How do you keep your weight down? How do you keep your muscle mass on if your joints prevent you from exercising to the point where you can keep those tissues healthy? So a cardiologist thinks the world centers around the heart. A neurologist thinks the world centers around the brain. Orthopedists think the world centers around muscles and bones and joints. But if you think about the biggest problem driving chronic disease as we age, orthopedic limitations are high on the list. So if we can manage those problems, remember, we can't regenerate them yet, but if we can manage them effectively, if we can take an arthritic tissue, a knee, for example, and we can reduce pain such that that person can remain active, can continue to exercise at a higher level with less pain, then guess what? Their general health, if they're disciplined, also should follow suit. So I like the application to orthopedic pathologies because they're crappy healers, number one, and number two, they're often the limitation preventing men or women from optimizing their health because they can't move their body because they hurt. Does that make sense?
100%, 100%. And I think the follow-up here from me is, where do now stem cells fall into the hierarchy of a fully holistic plan, right? Nutrition, sleep, cardio training, strength training, any other variables that we need to be considering. I think a lot of people hear about these things and, they've been categorized as higher end service. I don't think that they're super cheap to get involved in. So a lot of people, I think, hear them. It's like, oh, that's going to solve the problem, right? So I don't need to change anything else about my life. Where do they fall into this hierarchy, though, of making sure we have a fully holistic approach?
Yeah, it's a great question and an evolving one, I'll say. From my perspective, all of those things you just listed are critically important. So it's about prioritization. When we're evaluating a patient, we want fitness. We want maintenance of muscle mass. We might evaluate hormone optimization if it's appropriate. We might look at supplementation and nutrition. All are critical. But if they can't move because their back's killing them, all those other things are going to be less effective. So in that case, if the ortho issue is the limiting factor, let's address that and prioritize that first.
Got it.
Then, if we're doing a better job managing that problem, the limiting factor, then guess what? We're going to focus on nutrition. We're going to focus on fitness and health. We're going to focus on hormone optimization if that's applicable. So they're all tools in the tool belt. And our job, I think, in terms of looking at this holistically, is to prioritize which of those things is the biggest limiting factor preventing that person from optimal health, optimal performance, optimal wellness, being vital, longevity, functional lifespan, not only living longer, but living longer actively. Those are all the things that we're looking at saying, okay, where's our greatest opportunity to impact? And it's not that by prioritizing you minimize the other ones, but you hit the biggest limiting factor. That opens up a whole new world. Now with some momentum, my back's not killing me so much, or my knee's not killing me so much. All right, great. Let's try to get 20, 30 pounds off. Okay, let's look at hormones. Let's give you some energy back, right? Let's give you some focus and improve your sleep. And we start to little by little peel away the layers until we have a holistic approach. And now with modern medicine and things like customized and precision medicine, we're able to be much more specific in those types of therapies using something like your DNA, your genome, which is a fascinating area of medicine that's coming to light here more recently as technology has allowed us to dive into precision medicine.
I love that. So it's a full comprehensive consultation to identify what the biggest rocks are going to be. And then we move those first and then we fill in the rest. So for some, it may be stem cells, may be the first thing. For others, it may be optimizing some of these other areas, just dependent upon where that patient is at.
Yeah. So, I mean, people come to me with specific orthopedic issues. That's what I'm known for, and that's what drives them here. But a lot of times, guys will ask me, hey, I'm feeling lousy. I have symptoms of low T. Can you take a look at my labs and my biomarkers, and can we evaluate that? Let's look at my nutritional status and so forth. So what brings them in opens up opportunities to tackle all of them. But again, if you try to tackle all of them at once, sometimes you end up doing no good anywhere.
Exactly.
So prioritization allows us to engage the patient, work with them to solve that limiting factor. Now in their minds, there's a positive feedback, right? My doctor is effective. This system is effective. I'm going to listen now. I'm going to pay more attention. I'm going to have more engagement when we try to target those other things.
What are some of the biggest myths or lies or misconceptions that people are believing that when they come to you and they're saying, hey, I'm ready for some stem cells, and they have this kind of preconceived perception of what they're going to get? Like, what are some of those misbeliefs that people are buying into before they begin to work with a professional like yourself?
I think the single most important one is that I'm in my 60s or 70s and I don't have any good stem cells anymore. If you're in reasonably good health, and this has been proven by a lot of research, this isn't just me anecdotally saying this, but deep scientific research, you have plenty of good stem cells. It's about going and getting them and concentrating them. Now, as we age, our stem cells do decline. Our progenitor cells, our stem cells do decline, but not to the point where we don't have any anymore. One of my PhD colleagues always likes to say, if you didn't have any stem cells in your body, you'd be dead. Right? So the fact there's this great myth, somewhat pushed by the baby cell model, right, to try to promote that as a better alternative, that you don't have any good stem cells in your 60s and 70s. Well, who gets arthritic problems? Not 20-year-olds, not 30-year-olds, by and large, not 40-year-olds. All of our data in applying autologous, your own cells for your problems are in 50, 60, 70, and even 80-year-olds. And that data is very strong and very complete. It's not perfect. It's not 100%. Nothing is in medicine. But the biggest myth is that you don't have any good stem cells anymore. So that's by far number 1, 2, and 3. The second myth is that what we talked about earlier, baby cells or a younger adult human cells are better than my own. No scientific evidence, definitive scientific evidence to prove that today. Could that change in the future? Potentially. But today, no, there's no evidence to prove that notion. Even though it's a compelling value proposition, it's tempting, right? It's just so easy to grab that magical bottle of baby cells off the shelf and draw them up and squirt them into your knee or intravenously, or God knows where else they're going. And just magically everything is going to happen. What about the mechanisms behind how it works? What about how many cells did you dose? What about how many cells are even alive in the manufacturing process by the time they went into your system? All of those things are often things that are overlooked in application of cell therapies that are absolutely critical on this end of the equation, and to give patients the best possible chance for a return on their health investment, because these are expensive therapies. These aren't cheap. And when we're evaluating a patient, often we're looking at it transactionally. What's the likelihood of a return on your investment? My job is to handicap that. It's good, moderate, really good, lousy. The patient needs to know, based on what we know from research and anecdotally doing this for many, many years, what's the likelihood of success? They then can make a better informed decision whether or not to spend their money on something like this, but they need to be counseled fairly in order to make that good decision.
Yeah, you said here, as long as you're in reasonably good health, that you have stem cells that can be used. So when I hear that, I hear the healthier you are, the better your stem cells are going to perform if we use them. So, we're talking a lot about, these aging individuals, 50s, 60s, 70s, even into their 80s, healing kind of arthritis. We're going to have a large amount of audience that is going to be guys that are, mid 30s, early 40s, former athletes. Maybe they played D1 football and he's had this nagging knee thing for the last 20 years. He just got banged up in college. It's like he's never been able to fully repair it. Healthy, every other part other than his knee. Would somebody like that have a higher probability of the stem cells working because they're healthier overall, despite having one kind of like injury from being an athlete back in the day?
The answer is most likely yes, but we're working very hard to definitively prove that theory.
Okay.
Right. So, I mean, it makes logical sense. I'm almost certain that that will pan out, but that takes a lot of data collection and study and analysis and tracking people. But I'll give you one of my own stories that's applicable to what you just said. I was a college athlete, and I developed something called jumper's knee. I was a basketball player. Jumper's knee is where your patellar tendon, right where it meets your kneecap, starts to tear. And it is just a miserable injury for a basketball player. And I suffered through it, and I kept playing through it for a couple of years. And after my playing career was over, I just continued to have this knife-like pain right at the bottom of my kneecap. And I just dealt with it, but I wasn't able to work out and train the way I wanted to. And even just, basic exercise was very uncomfortable. So back in the very early days of cell therapies, in the platelet-rich plasma was super innovative days. This is probably, I don't know, 2004, 5, 6, somewhere down there, way down a long time ago.
Wow, yeah.
My options were a huge reconstructive surgery where they basically cut the tendon away from the kneecap, drill through the kneecap, sew it back up there so it heals, and it's about a year recovery. Now, I wasn't a competitive athlete anymore, so that didn't make a whole lot of sense to me. So this little PRP thing that I started researching back then kind of made some sense. So I literally injected my own knee with PRP 3 times back then. Now, over the course of about a year. The first one did nothing. The second one led to about 40% improvement. The third one was, I don't know, 15, 18 years ago. And the problem isn't 100% solved, but it's like 80, 90% solved. And that's really one of the things that that really drove me to say, I think we might have something here. The notion of helping the body help itself, heal itself made sense to me versus how I was trained, which was, medications and steroid injections and surgeries and all the things that we were trained to do, which was the best option we had back then. This filled a void, a gap of, we have something to offer those people that aren't quite surgical, but aren't responding to traditional therapies. It got us in the game. And that was so critical to have, because we just had so many patients who were just kind of in limbo, in therapeutic limbo, suffering with this stuff, not wanting surgery and not responding to anything else. So it was fantastic. But that's an example of, I was pretty young back then. I'm 53 now. And to answer your original question, I wish I got to people sooner, but the problems often aren't severe enough to get them through my door.
Yeah.
In theory, if we intervene earlier, the problem's not quite as bad. We should not only be more effective, but also have the opportunity preventatively to lessen the likelihood that the problem is going to advance as quickly or as severely over time. Okay, that takes a long time to try to prove that model out, but it makes perfect physiological sense when you think about it.
Is that where you see this eventually getting to? And are we even there yet, where guys are using this more as a optimization versus a recovery? I think the testosterone, the hormone industry has kind of proven this. Like you go back maybe in the early days, you're a little bit older than I am, but I can remember hormone therapy was like when somebody's life was like just in the complete gutter, right? It's like guys weren't using it until they realized like, hey, my testosterone is in the tank. Now you hear guys in the entrepreneurship space and the high performance space and all of these circles that are like, okay, my hormones they're in a good, healthy range, but if I can get them to a top level of the healthier range, I'm just gonna have a better quality of life.
Yeah.
Are guys beginning to see stem cells as the same thing? It's like, I'm not hurt, but I know it's going to improve the overall quality of my life. And that's really what I want to maximize those years. Are we there yet, or do you see it getting there?
I see it getting there. I think it's a little bit misconceived in that people are thinking from this perspective. I'm going to inject a hockey player after a playoff run. They're just beat to crap. I mean, they just played 90 games and, their body is a mess and they have 2.5 months to recover. So what are these guys doing? They're going offshore and they're getting intravenous allo baby cells, which have no evidence to prove that they work. But the thought process to your question is, I'm going to be proactive to try to help my body heal. And hormonally, for good reason and bad reason, it was kind of viewed the same way. So there's a lot of interesting synergies between hormone optimization and cell therapy is what we do, which we could talk about. But I think the perception is that's how it should work. From my seat, I look at it as optimization of a tissue, a more specific problem. A knee, a shoulder, a rotator cuff, a disc in your spine, not general wellness, general recovery, general health. I don't think stem cells have any clear evidence that if you just inject them into your system, into your circulation, that they're going to make you healthier, younger, better. Okay. Because what happens is something called the first pass effect. When you inject stem cells into your vein, 99% of them get caught in your lung and your liver and never make it past there. Now, they might sit in there and secrete things that could help you in theory, but it's very hard to prove that that has any positive benefit. Yeah. So thinking that we inject stem cells into a vein and they're going to go to your brain and they're going to go to your heart and they're going to go to your joints and they're going to go, not true. They don't ever get there. It's not possible. So to answer your original question, I don't think optimization we're there yet. Quite frankly, I think genetic engineering probably represents a better option where we can program a cell to go into your body and perform a specific function. We have that capability, but it's going to take a lot of safety research over the next 10, 12, 15 years to make that safe and viable, because that's going to be categorized as a biological drug.
Got it. Yeah, no, that's a really good. I'm glad I asked that question because that is a good understanding for me. And I think I was of the line of thinking where you were saying, right? It was going to be like, if I take the hormones, it's going to raise those numbers and then everything's going to improve. It's like, it's not that case. It's still going to be this isolated kind of recovery mechanism.
For cell therapies. Now, hormones is a different story. Hormone optimization can help many tissues. And we see this with testosterone optimization or testosterone replacement. Yeah. And they're two different things. Right, optimization and replacement are two different things.
Of course.
But you mentioned, a culture shift in the medical community that, and culturally in the male community, that historically we didn't recognize the equivalent of menopause called andropause. Right, as women, as they age, their ovaries stop making estrogen. They go through menopause. That's when their child-rearing years end and the second part of their life begins. Well, we've been treating that with estrogen and progesterone replacement for many, many years. And the safety of that and all that's been called into question, but it's survived and looks to be a healthy thing for most women. By the way, those are steroids. So your grandma, if she's on estrogen, is on steroids, right? Because estrogen and testosterone are steroidal. Okay. Now there's specific type and there's different types of steroids, but I always laugh that, men who take testosterone optimization for medical reasons are on steroids. Well, yes, that's technically true, but they're on it for a good reason. And the knock and the appropriate concern was if we replace a 50-year-old male's testosterone to a healthy level, high normal, right? High normal, what a 30-year-old might have, is that dangerous to that person? Well, the answer with extensive research over many, many years is no. It does not clearly increase your risk of prostate cancer, colon cancer, or heart disease. If it's managed and you're checking your levels and keeping them to a healthy correction, not a super physiologic correction where we're pushing it beyond normal, but a healthy correction looks to be a good and healthy thing to do. Who doesn't get Problems. Young, healthy males with normal testosterone levels. Right? So why would a 50-year-old, if we correct it to a healthy, normal testosterone level, all of a sudden develop all these problems? Just doesn't make sense. And the data, fortunately, proved that that is actually an appropriate position to have. So that's my take on, should we offer men testosterone replacement or optimization? The answer, based on the data, is yes.
I love that. I love that. And we've done multiple conversations with experts in that field, and I'm a proponent of it. I'm not a proponent of people doing it unless they make that choice in their life. And that's a decision that bodybuilders and competitive athletes decide to make. But for our audience out there, from an optimization, health, longevity, performance standpoint, if your numbers are low, getting them into that healthy or the high normal level, it is a game changer.
And here's a really interesting question that it's going to take us a while to try to answer. And that is, if someone has a lousy hormonal axis, so their testosterone is low, thyroid might be low, their hormones just aren't, the body's just not making hormones as a function of aging like it did. If we correct that, will their cell therapy work better? So if you correct the hormonal axis, your cells should get healthier because your hormone profile is in balance at a healthy level. Does that translate, when I go in and collect your cells and apply them to a problem, does that translate into better success? The answer is we think so, but that's something we're tracking and looking at, because one of the questions we see in a 60-year-old guy who comes in with a knee problem is, should we fix his, or take a look at his hormonal axis first, maybe fix that first before we treat the knee? So I don't know the answer to that question yet, but it's an interesting one to research and dive into, because it goes back to this holistic paradigm of, comes in with one problem, there's an opportunity to fix 1, 2, 3, 4 other problems at the same time.
Yeah, well, that was a callback to kind of that previous question that I had asked you when you had said, a reasonably healthy individual in their 50s, 60s, and 70s. And I was like, well, okay, so is a younger, more healthy individual going to have a higher probability of these things working? So if we can get the 60-year-old guy to be optimized, it's going to draw out, it's going to lengthen the time that they're working with somebody, but the end result is going to be not just fixing the injury or fixing what they came in for the stem cells, but just an increased overall quality of life. And I think that's what we're about here, is promoting, how do we improve the overall quality of your life, not just fix an issue.
Well, managing and interacting with men who are symptomatic with low testosterone. Not everyone is. You can have low testosterone and feel great. You don't fix it in that situation. But a guy who's low and is feeling awful, you've seen these people. There's no way that guy is going to perform well. No way. No, he can try as hard, and he can be stoic and disciplined and have the greatest habits in the world, but the gas is just not in the tank. So you fix that guy, guess what? He's dynamite. And I think there's still, it surprises me that there's still so many misconceptions around this topic of should we or shouldn't we medically correct hormones in a guy who's low and symptomatic. It's a no-brainer in my opinion. And look, there's contradictions to every rule, and it's not for every single person, and everyone's sweet spot may not be exactly the same. It's not a cookie cutter. There's a little bit of trial and error and dose adjustments and so forth that need to happen, but the upside clearly outweighs the downside from my perspective, and I think the tide is turning on that, and more people are accepting it.
Yeah, a segue and related, but not 100% related to this hormone conversation here, is ED, erectile dysfunction, sexual performance issues. If you look at those numbers, they're higher than they've ever been before. Many factors driving this, right? Hormones being one of them, pornography addiction being another one, maybe what's in our food and the chemicals. And, you see the data around just hormones with young men as compared to 30, 40 years ago. How are stem cells effectively being utilized to not fix or solve, but aid in erectile dysfunction issues?
It's a great question, and an area that I'm quite excited about, because not every guy has a positive sexual response to testosterone. About 50% don't, from a erectile quality standpoint. Energy's there, but so imagine giving a guy his energy and his libido, but he still has erectile quality issues. That's a disaster. So one of the things I'm excited about is, penile tissue is a tissue just like any other, and there's an opportunity to rejuvenate, revitalize that tissue with cell therapies, because it's a tissue. We can revitalize it. So in that case, it's about blood inflow and blood outflow and kind of getting that back into frame. But the data on using first platelet-rich plasma, which is basically isolating, concentrating platelets from your blood, injected into penile tissue, and then combined with shockwave therapy. So shockwave is an acoustic therapy, which helps to kind of open and promote blood flow.
Is that Gainswave?
Gainswave is one of them. There are many.
Okay.
Gainswave is a brand name. That's like Coke
Gotcha.
versus
Okay.
Cola, right? So,
Gotcha. Okay.
so Charles Reynolds is the guy that coined the phrase P shot. Okay, that's his methodology, but it's really basically platelet augmentation of penile tissue and erectile function. And the data on it is very good. We've treated lots of men with that type of application, and they do great. And they're so thankful. And if you combine that with, again, a more holistic approach, it's a huge piece. It's a massive void for these guys that are working hard and trying to make themselves better. But they have this huge, think of the confidence crush that is if you are fit and vital and have great energy and have great libido, but you cannot perform. It's a monster problem. And if you can give that back to a guy, what a quality of life game changer. So now we're starting to see a transition where, okay, well, if PRP worked, what about cell therapies? And the cell therapies that we use based on, again, on Food and Drug Administration and from the patient's own are either isolated from bone marrow tissue or from fat or adipose tissue. Okay, so there's some papers out now using stem cells or progenitor cells derived from fat injected with PRP into the penis that even looks a little better than PRP alone. So we're starting to track that and watch that data for ourselves, because we always track every single patient we treat in our database. We don't want to just take somebody's word for it. We want to prove out models ourselves. So we're excited about that opportunity, and it looks like that's performing pretty darn well and is having a little bit more sustainability. The problem with PRP and PRP augmentation is you have to redo them. It's usually a series at first, and then every year you have to kind of maintain it. Well, if we could apply a technique that would be more sustainable, that you don't have to keep doing it over and over again, obviously has advantages. So long-winded answer to your question, but it's a tremendous area of. The difference, though, is, remember, orthopedic tissues are crappy avascular tissues that don't heal. That is the complete opposite of penile tissue.
Yeah.
So it's much easier to stimulate than a cartilage or a disc or something like that. So it responds really nicely and very robustly to these types of therapy. So it's a great area, still needs research. No one has considered what is an optimal dose of cells or PRP. That's a lot of the work that we do, is trying to optimize dose for different problems. So ways to go there, but the general trends are that it works very nicely. It's extremely low risk. And for the guy who's not responding to other methods or even medications alone for that reason, Cialis or Viagra or whatever, this is a good option that doesn't involve taking a pill every day.
Yeah, that's awesome. I had I mentioned at the beginning, I've known a couple of guys that have gone overseas or out of the country for some of these therapies, and one in particular went and got some out of the country therapies specifically for that issue. But it's sounding like what you guys would have done may have been a little bit better of an approach, because it would have been his own cells as opposed to perhaps he was getting.
Well, we don't know. We don't know if it's better, right? That's still, because it's never been compared. Like I said at the beginning, there's no head-to-head data. So again, what we fall back on are two things: what we're legally allowed to do, but two, what's safe. So if I can use yours and it works just as well and it's safer, why wouldn't I do that? If it's coming from someone else, I don't know who the donor was. Was the batch and lot different from 10 different donors?
Yeah.
Are they all the exact same therapeutic potential because they're from different? No, we don't know answers to any of these questions. If I use yours, I know they're encoded to help you, and they're safe. You can't reject them. And if we can get the dosing optimized, again, that's our research, then it creates a predictability model. So let's say you're coming to me for a problem, Frank, and I can counsel you in one of two ways. Well, Frank, the data says that there's a pretty good likelihood that this will work, and it's going to cost this much money, and it's a pretty good chance. That's option one. Versus, Frank, we've treated 500 people with your problem, and there's an 82.7% chance that you're going to get at least 70% improvement for 5 years. You see the difference between the two methods, right? Our goal is to create predictability models so the patient can make a better informed decision. But what does that also open up? It opens up billing and coding channels. If we can predict response, Now you can go to a third-party payer, a Blue Cross Blue Shield or an Aetna or something Medicare, and say,
Yeah.
we can predict response. Now we believe by applying this therapy to a subset of your patients, we can save you $600 million.
Mm-hmm.
That's the language. That's the pharma model. That's the language they understand. So a lot of people ask me, how come this isn't covered by insurance? It's not due to a lack of data. It's due to a lack of the right data that's in a language that a third-party payer is going to pay attention to, which is predictability of response, translating into what? Cost savings, because these are businesses.
Yeah.
That's how you have to do it.
Once somebody starts to go down the path of cell therapies, like what is their commitment to this? You know, we've talked about hormone optimization here, or maybe in hormone replacement. That's depending on how you dose it, you know, weekly, multiple times a week. Now they're doing daily injections, but it's something that once you make that choice, you're committed to having to regularly do this. If we opt in to get cell therapy, is it like a one-time procedure? You inject them and you're good. You mentioned something about a 5-year lifespan here. What does our commitment to staying involved in the therapy look like?
Yeah, there's a lot to it, and when it comes to a cell therapy, we talked about PRP necessitating, often repeating the treatment. It's just
Yeah.
not power enough to hold for longer. But cell therapies are a little different. Our goal with a cell therapy, let's use knee arthritis. I like to use that one because where we have the
Yeah.
most data. So someone comes in with a knee arthritis and they want to consider a cell therapy. Make sure they're not surgical. Make sure they failed conservative management, whatever. Our goal is to apply one application and get at least years, plural, years of improvement out of it to make it cost effective. So if someone comes in and we apply cell therapy and they say, man, I felt great for 8 months, that's a failure. It's just too expensive to justify that duration of relief. But if someone comes in and they get 5 years or 6 years, I have some patients that got 7 or 8 years out of it, that's an extremely cost-effective therapy.
Yeah.
Right? If you compare it to the alternatives, excluding quality of life, that's improved during that period of time. So we are looking for a much greater duration from a single application. Now, it gets into situations where someone's a partial responder. So someone comes back after 6 months and says, I'm better, but I'm still not quite where I want to be. We reevaluate from scratch. You don't automatically just hit it a second time. Well, let's look at this and determine if it's appropriate to think about a second therapy. We're probably undertreating these problems because it's cost prohibitive to just have at it because it's expensive.
Yeah.
So if we treated non-responders or partial responders more aggressively, would we get some of them to convert from non-responders to responders? I think so. But again, we're talking about risking a whole lot of money with no guarantee. So if you don't respond, the likelihood of responding to a second treatment goes down in terms of the odds and predictability. So we're starting to gamble with a lot of money here. The biggest risk of a cell therapy using your own cells, I tell this to patients, the biggest risk is the loss of money. We wasted money because we didn't buy our outcome. This is an investment. You make an investment in a business goes belly up, you lose your money. It's a terrible investment. You invest in a cell therapy and you don't get your outcome. Disappointing for you, disappointing for us. Obviously, it's not what we want. So that goes back to ethical decision making of picking and choosing who you're going to do this and counseling them appropriately. If it's a long shot, the patient needs to know that it's a long shot. If it's a high likelihood of success, obviously we counsel that, and they're more likely to to want to move forward. Even the long shots often want to move forward, but at least they're counseled fairly. Every single patient I see hears these words. It's possible this will not work. It's possible. The odds are good. The odds are in your favor, but it's possible. We have non-responders, and that's disappointing for everyone, but it can happen. And I tell this story a lot. The best compliment I can ever get as someone who does this kind of work is a patient who failed to respond to treatment that refers 10 more people to see me. That's the greatest compliment I can get, because it wasn't that they did well with treatment. It's that they were treated fairly and honestly. And, they appreciated that so much that they felt that they were handled and managed correctly. Didn't get their response, disappointing, but they thought enough of the process to refer someone else. Now we work very hard to prevent that scenario from happening, but it can happen and patients need to hear it's possible this will not work. The other thing I tell every single patient is no one has to do a stem cell therapy. We're not talking about cancers. We're not talking about strokes. We're not talking about life-threatening diseases. In ortho, no one has to do this. This is an option. So let's weigh the pros and cons of your options. And if this one makes the most sense, great. We're going to do the very best job we can to try to give you that home run. Maybe we get a triple. Maybe we get a double. We're going to shoot for the home run, but we'll take whatever we can get. And then it's a question of, are you good enough to not do a surgery, to be able to live the functional quality of life that you want?
That is fantastic, man. And I think we'll drive it home here in a couple of minutes, but a couple of questions maybe for the audience that is thinking about, is this right for me? You're obviously located down in South Florida. So anybody that is in the Miami, Fort Lauderdale, even if you have means to travel, get down there, check out David and the Karli Center with all the work that they're doing. But what type of questions should somebody be asking themselves to determine if they should begin to explore cell therapy? And what questions should they be asking their provider, their practitioner, to determine if this is a good person that I'm willing to make this investment into?
If I may, I'll answer the second part of that question first, because I think it's the more important one. So since early mid 2000s, but certainly in 2010, when I founded our biotech company, that company was tasked with doing one thing: knowing exactly what was in those products so we could study the effect of cellular dose and response. 99.9% of all of the stem cell therapies that I've done across the world, physician had absolutely no idea how many cells they gave. 99.9%. Absolutely no idea how many cells were in there or how many of them were alive. That is unacceptable, in my opinion. So we set out to fix that. We said, we're going to know how many are in there, and we're going to study over time how many are in there so that we can start to match cell dose to patient. You don't treat a 75-year-old the same as a 23-year-old. And problem. You don't treat a cartilage problem the same as a tendon problem. It's not a one-size-fits-all solution. How does that relate to your question? What you need to ask your doctor is, are you going to know how many cells are in there? Most of them will not. In my opinion, it's a roll of the dice. Maybe you get a good biologic with lots of cells. Maybe you don't, but the doc won't know. I get a lot of second opinions. I failed this already. What can you do for me? Well, I said, well, did your doctor know how many cells were in there? No. Then I can't assume you failed it. How do I know you didn't get a crappy dose? It's a huge problem. So the number one thing is, are you going to know how many cells are in the product? That requires a lot of work and measurement, and it's very tedious. It's hard. I say it's easy to do this medicine poorly. It's really hard to do it really well. And when patients come here, they're like, oh my God, I had no idea all that was involved. I thought you just come in and you just shoot me up with some stem cells. They're here for a couple hours often because we're tracking and monitoring and measuring and doing all this kind of stuff. So that's the first thing. Does the doctor know what's in it? The second one that's important is, are they going to guide? Are they going to use guidance, ultrasound or x-ray guidance, to ensure that the cells are delivered exactly and precisely where they need to? Blind injections can miss. If you miss, you can make the best biologic in the world. If you miss, it's not going to do any good. So are they using guidance? Are they trained to do guidance? Okay, what's their background to do so? Those are the two most important questions to ask of your physician. Third one is, are you tracking your outcomes? Every single patient does a pre-treatment survey, a questionnaire that's body part specific, one for shoulder, one for elbow, one for knee, et cetera, one for penile function, et cetera. And then at 1 month, 3 months, 6 months, and 12 months, they get follow-up electronic emails from us or text messages to fill out that same form. And we track every single one so we can see how they're doing. So that we can then provide, we're using machine learning and artificial intelligence to start to sort through, well, this plus that minus that plus that equals success. Because there's lots, as we said before, progenitor cells, lots of different cells. There's not one stem cell. There's thousands, theoretically, of types of stem cells. So it's very complex medicine. So are they measuring? Do they know what's in it? Are they guiding? And are they tracking outcomes? Three most important questions to ask of your provider. In terms of should they consider candidacy, I tell patients this. It's not hard for me to find something to inject on you. Everybody's got something. That doesn't mean it needs to be done. Okay. Yeah. So the question is not, should consider it, but you should go to the doctor and work through the process. And a lot of times patients come to me, they already know what they want. Their mind's made up. We still go through the process. Here are your options, even though they already, and a lot of times they get kind of annoyed. I already know what I want. Nope. You got to hear this. Here's your options. Mm-hmm. Okay. Because it's important for them to know. So should they consider it for an ankle sprain? Do you need stem cells? No. If you've got a cuff tear, or you've got a chronic problem, or you've got something that's limiting your quality of life to the point of making this appropriate, the answer is, hey, find a quality practitioner and give it some consideration. Is it right for everyone? No. There are times where not doing stem cells is the better option. And that's disappointing for patients. They kind of have all this hope, and sometimes it's not the best thing to do. But consider it. I think, more and more people are considering it, but you have to view it through the lens of like an investor. It's possible I could lose my investment.
Yeah.
Am I willing to do that? Doctor's job, handicap this so you know the odds, and you decide if you want to invest in your health in that capacity.
Yeah, fantastic answer, David. I appreciate all of that. I appreciate today's conversation more than man. Tell the guys out there where they can connect with you, where you're hanging out online, your socials, and anything kind of big and upcoming that you're excited to share with them. And we'll wrap it up with our last and final question here.
Yeah, so after 20 years of practice in Vail, Colorado, we opened Karli Center here in South Florida, just south of downtown Miami. We're in North Coconut Grove. And we'll be opening up some new centers, first in Florida, and then hopefully regional as well with a lot of our affiliates. So we can be found at karlicenter.com. And our staff is fantastic. This is very much a model that's purposeful and devoted towards the patient experience, not just delivering great clinical care and science, but also making the experience a good one. If patients have a good experience, they're more likely to tell others. It's the greatest natural marketing, and doctors historically do a pretty lousy job at that part.
Yeah.
So we really focus on customer service part of it as much as the science. So we're in South Florida. About 65-70% of my patients travel from all over the world to come in here and see me. So we certainly appreciate them, and we're honored that they would jump on a plane, come down here, get a hotel, and think of enough of us to come do that. But we certainly, being new in the South Florida area, want to make this known. And part of the reason I'm doing more podcasts and getting more vocal is to let people know that we have this amazing resource here right in South Florida that is trying to truly legitimize this space and optimize it. It has such great potential, everyone agrees, but it has to be done correctly. It has to be done responsibly, and I think it can be.
Yeah. Well, I appreciate you guys and what you're doing and providing out there to the population. And yeah, if you're trying to get people to travel, it's not hard to get them to travel to some of the most beautiful places in the world, right? So being down there in South Florida.
Well, it was a bit strategic, Frank. We didn't choose Miami for no reason. Also, after 20 Vail winters, I was ready for a little bit of heat. So that was nice. So if people want to kind of see me and what we're all about, I'm pretty active on Instagram. That's the best social platform for me. You'll see a lot of stuff on fitness. I'm, like you, very much intertwined with fitness and supplementation and hormone optimization, as well as all the cell therapy stuff. So best place to see and kind of get exposed to me is our website or Instagram. It's just David Karli.
Awesome. And guys, we'll have all that plugged down there in the show notes with the website, the links, the socials, and all of David's information. So as we wrap it up here, the title of our show is called The Superhuman Life. I love to end it with the same question for all of our guests. I used to have this little spiel where I went through and I tell you what living a superhuman life meant to me. I don't do that anymore. So as we wrap up today's conversation, Dr. Karli, how would you define living a superhuman life?
Fighting the beautiful fight against the inevitability of aging is the superhuman life. We're going to age. Doesn't mean we have to age poorly. Aging well is the key, in my opinion. Right? I'm 53. I'm aging. I'm not 28. I can't do the things I was when I was 28. But I can fight and fight aging as best I can to stay active and maintain muscularity and maintain my vitality across all disciplines of my life. Sometimes we need help, and that's when you come see a guy like me or another provider. So from my perspective at this age, my answer to your question is fighting the good fight to maintain vitality despite the inevitable. Is that futile? No, that's a beautiful fight. There's nothing better than fighting that fight and doing it well and living your best life knowing that you're going to fight the battle but lose the war. That's okay. That's okay. As modern technology continues to advance, it's not about living to 200. It's about living to 100 and still being active. No one wants to live to 200 and be in a wheelchair for 30 years of it. So I think our focus on functional lifespan is the appropriate one. I'm getting older. I intend to battle it all the way, and it's hard, and I hurt. And there's a lot of downsides to it. That, in my opinion, is the ultimate fight that is truly worth the effort and worth the work.
Yeah. Amen to that, man. I agree with that wholeheartedly. Guys, connect with David, the Karli Center. Check out his Instagram. If you're interested, he's the guy to contact about these stem cells. If you guys have questions, reach out to him, reach out to myself. We may bring him back. We may try to link up and do something in person, because we just found out here a couple hours ago that we are as close to each other as we are. But guys, make sure to connect with him. Share this episode across all the platforms. Make sure to rate, review. But for Dr. David Karli, your host, Frank Rich, we love you guys. We'll see you in the next one.